Hi there, thanks for joining us on our talk called Improving Care for Patients Experiencing Poverty, Facebook Live discussion with Dr. Gary Block. Dr. Gary Block is a family physician who practices at St. Michael's Hospital in Toronto, Ontario, and is an advocate, an educator, and researcher on issues related to poverty and healthcare. He's also the chair of the Ontario College of Family Physicians Committee on Poverty and Health. The first 15 minutes of this session is going to be a presentation by Dr. Block, followed by a question and answer session and discussion. So please feel free to submit your questions during the presentation as well. We'll be taking note of them and asking them after the presentation. Welcome to Dr. Gary Block.
Thank you so much. It's great to be here. So I want to spend these next 15 minutes just giving you a sense of what it means to intervene in poverty and where the clinical tool on poverty fits into this idea of interventions into poverty. So, and I really do encourage you to send your questions in as I go through this, because I'm really looking forward to the discussion piece of this evening's event. So when I think of intervening in poverty, I often come back to two major starting points. And I think these starting points should be familiar to most of us. The first one of them is our patients. I mean, this really comes back to the stories that we hear on the front lines of family medicine care every day, right? Stories like that of Vera. Vera is someone I've known for about 8 years. She's someone who's been diagnosed with diabetes, with congestive heart failure, with osteoarthritis, with depression. She's someone that I've done everything I'm supposed to do for, prescribed the right medications, ordered the right tests, referred her to the right specialists, and really her health situation hasn't improved. And when I turned to her a few years ago and asked her, you know, why is it that things just haven't gotten better? She turned to me and she said, you know, Doc, you try living on less than $1,000 per month from welfare. Right? She said, you try living in an awful apartment where she faces infestations of bed bugs and mice and cockroaches, where she can't even leave her apartment because the elevator often doesn't work and she can't get herself off of the third floor where she lives. And it's her type of situation that reminds me over and over again that my patients face social challenges to their health as much as they face traditional medical challenges to their health. So this is one of the big pushes for me. The other one is the evidence. And I'm not going to spend a lot of time going through this incredibly vast body of evidence that links poverty with poor health outcomes. But I will remind you that poverty has been associated with an increase in the prevalence, the mortality, the morbidity of just about every chronic illness, acute illness, even accidents and trauma. And it's been shown to have particularly strong impacts on children, and truly impacts right from their time in the womb all the way through childhood. And in fact, the evidence shows that kids can't totally overcome the health impacts of having grown up in poverty, even if they change socioeconomic status later on in life. So a real push to intervene early. And I also like to remind myself that it's not just about absolute income, it's also about income inequality in our society. And what you see on this graph in front of you is this dramatic rise in income inequality that we've seen in Canada over the last 40 years or so. And the health evidence has shown that societies that have increased income inequality do worse overall. So even richer people do worse in societies that are more unequal than in societies that are less unequal. So to kind of sum up the evidence, and I promised I'd be brief on this part, I wanted to show you this graphic, which actually comes out of a report put out by the Canadian Medical Association. And what they did was they estimated the impact of different factors on our health. And they actually estimated that about 50% of our health is determined by just how we live, right? All the factors in our life. And much of this is really about the social determinants of health, like poverty. And only about 25% of our health is determined by our access to health care. So I like showing this because I really think about my work and really the work that the poverty tool represents as being about shifting our impact from that green zone into the red zone, right? Really broadening our ability to impact our patients' health. So this is really where the poverty tool came from. And what you see here is about the third iteration of the poverty tool, but this is the latest one, the most advanced one, and the one that I've built with the Center for Effective Practice and now the College of Family Physicians in Canada. And what this offers is a simple 3-step approach to dealing with an issue, a social threat to health like poverty. And it's really designed to be used in a typical frontline family medicine office setting. So I just want to spend a couple of minutes giving you a taste of what these 3 steps look like, just so you can have a bit of a sense of what it is we're really talking about. So the first step should sound quite familiar. This is about screening, right? But this is about screening for a social issue, and in fact, very specifically screening everybody for their income. And I don't think there's one way to screen people for income, but what's offered on the tool is a simple, easy to ask question. Do you ever have difficulty making ends meet at the end of the month? And it's a question that's been shown to identify almost everybody living below the poverty line. It's also been shown to be very easy for providers to ask and very acceptable for patients to hear. And to me, this idea of initially identifying who in your practice is threatened by the health challenges of poverty is absolutely foundational to any attempt to actually deal with your patient's poverty from a health perspective. The second step in the tool is a little more esoteric, but I think it should become clear what I mean in just a moment. So really what this is about is matching that evidence linking poverty with poor health outcomes with how we practice, right? And I often like to introduce this concept by using an analogy, right? Which I think it should be a fairly obvious one, which is this question here, which is if a patient smokes, does that change the way you approach your screening and your diagnostic decision making, right? And of course it does, there's no question. So my question is, given what we know from the evidence about that link between poverty and poor health outcomes, should poverty similarly be affecting our clinical decision making? And what we do on the poverty tool is we actually just offer up a sampling of the evidence. This is evidence that's local in most cases, at least Canadian evidence, to start twisting our minds around this idea of how we adjust our clinical thinking to this idea. And just a simple example, I mean, if I say that someone comes in, they're in their mid-30s, they want an annual health exam, should we be ordering, for instance, routine diabetic screening, right? And the evidence-based guidelines would say probably not, unless they have another risk factor. And let's say this person doesn't, but then let's suggest that they have been living on social assistance for the past 5 years. Does that change the way we think? Right? And again, the guidelines don't guide us on this, but if you look at the evidence, the prevalence of diabetes is at least double amongst the lowest income group as it is amongst the Canadian average. So I would propose that we should be changing the way we approach a patient like that, right? And similarly, we can look at the other evidence and think about how we incorporate that into our clinical decision making. The third step of the tool is the one that people, I guess, are really waiting for, the one they get most excited about, and this is the one that proposes that we can actually intervene to improve our patient's income. And now I'm talking here about interventions with individual patients. Of course, we need, big level policy change and systems change to really deal with social issues like poverty. But we also need to start doing what we can to impact our patients and the threats they face by living in poverty. So what we propose on the tool is just a simple set of questions to remember. Some of them are kind of surprising, right? Like this first one, which suggests that we should ask everybody if they filled out and mailed in their income tax forms. Now, I'm going to show you the kind of impact this can have for a low-income person in a moment, But first, just to give you a sense of what's on the rest of this part of the tool, what we've done is take different high-risk demographic groups and offer simple questions that help guide people towards some of the highest yield income security programs that are available to them, both provincially and nationally. Right? And these are things that I think are absolutely worth exploring and can have an incredible impact on a patient's income. But just to give you an example about how this plays out in practice, let's take the situation of a single parent who has 2 young children. She's working part-time at a low-wage job, earning just $14,000 a year in income, so certainly below any conception of a poverty line, and she's paying about $800 a month in rent. So I sit down with her, I speak with her, and it turns out that she hasn't filed her income taxes in years. She figured, why bother? I don't have the time, and I'm not going to pay taxes anyways. So I send her off to the local income tax clinic, and it turns out that she qualifies for over $18,000 a year in extra benefits just through the income tax system. Right? So well over a doubling of her income. And I think you can imagine as well as I can what kind of impact this is likely to have on her health and, of course, the health of her kids. Now, I often get asked the question whether there's any evidence that income interventions are effective. And my answer is we're starting to build some evidence, and there are a few bits and pieces that we can pull from. There's certainly a lot of conjecture we can make just given what we know about the link between poverty and poor health. But there was a really interesting study that came out of Manitoba about a year ago now, where what they did was they took low-income pregnant women and they randomized them. And they gave the intervention group $81 per month in extra income just for the time that they were pregnant. And the control group received just whatever they would have normally received. And they found that over the course of the study, and they enrolled about almost 4,000 people in the intervention, 10,000 people in the intervention group and about 4,000 in the control group. And over the course of the study, they found the intervention group showed a lower rate of preterm births and low birth weight babies, which I think is a pretty astounding finding given the low amount of an income supplement and the short term that this was provided for. So the wonderful thing about doing this at the College of Family Physicians of Canada is that I can advertise the fact that the tool has now been spread nationally, thanks to the support of the college. So there is now a version of the poverty tool in every single province and territory across the country that has been tailored with local resources and local evidence wherever possible. So I'd encourage you to take a look online and dig up your local version of the poverty tool. So, and I think it's also worth mentioning that a couple of our national medical organizations have picked up on this idea and have started to develop guidance for us in terms of how to intervene into social issues like poverty. What you see here is the cover of a report put out by the Canadian Medical Association talking about physicians and health equity. And I think really importantly for us as family doctors, a report that was put out by our national college called Best Advice on the Social Determinants of Health that really builds out this idea of how we can intervene and deal with the social challenges that our patients face. So, I often get asked the question, what else is being done, right? And we get that the poverty tool is focused on individual physicians with individual patients, generally in a single office type setting, or at least in the context of our offices where we work one-on-one. And I just want to end off my talk with giving you a bit of a taste of kind of where this is going next, and really looking towards some of the exciting multidisciplinary health team-based interventions that we've been developing largely in my family health team at St. Michael's Hospital in Toronto. And just to give you a little bit of context, this is a very large family health team. We have over 70 family physicians. We have over 200 staff, allied health staff and other staff on the team in 6 clinics supporting over 40,000 rostered patients. So a really diverse setting in which to test out new interventions. And this graphic you see here is actually our latest strategic plan. You'll notice in orange that one of the pillars of that is around advancing systems of care for disadvantaged patients, including positively impacting the social determinants of health. So this has been wonderful for me to work with. It's a great setting for people with my type of interest. And I'm not going to spend a lot of time describing to you what we've done, but I think it's worth, again, giving you a taste. So this graphic here shows the range of interventions that we've been trialing in our team, all focused on addressing the social challenges our patients face. Just to give you a sense of what these look like, for instance, on the income side, we now have 2 full-time income security health promoters whose entire job it is to work on improving the income security of our patients. We have something called the Health Justice Initiative, where we have a full-time lawyer funded by Legal Aid Ontario who focuses on the myriad legal needs of our lowest income clients. We have a community engagement specialist who tries to bring the community voice into the work that we're doing. We now standardly collect health equity data on all of our patients as a way of starting to get a sense of who we're serving and how well we're serving them. And this is just a taste of what we do. I should also say that we do have a social determinants of health committee built into our team that helps guide this. And we also have a very strong research and evaluation program that is trying to build the evidence base for us and get a sense of what actually works into the future. So I'm going to leave it there. That's a very brief overview of many, many years of work in this. And I'm really looking forward to the discussion that comes out of this work.
Thank you very much, Dr. Block. This is very informative. We have several questions that came in advance that I'd like to go over first. Primarily, please describe the development process of the tool.
Sure. So the initial tool was actually developed by me as an adjunct to educational sessions that I was doing, focused on this idea of intervening into poverty. I never expected that the tool itself would take on such a life of its own, but it did, right? And so it spread, first of all, through Toronto, and then was picked up by the Ontario College of Family Physicians, and then picked up in an even broader way by the Centre for Effective Practice. And then, as I mentioned, the College of Family Physicians of Canada took it up. And the process the CFPC went through to build this into a national tool, or really build versions of the tool across the country, was that they used local provincial colleges to identify champions in each province who went through the tool, who made sure that the approach and the resources felt relevant locally. And they ran an evidence-based survey again, looking for local evidence, and then vetted that through family physicians in each province and territory to produce the versions that were relevant within those local settings.
Another question we received, how can physicians learn to deal with social issues like poverty, and what role or roles can physicians take on to influence colleagues and policymakers to make a positive change? You mentioned policy earlier.
We're jumping into the big questions. So I think there's kind of 2 pieces to this, right? So one piece is around what physicians can do to educate themselves. Because really, I mean, the tool itself is a starting point. And I think like any area of family medicine, the deeper you go, the more knowledge, the more skills you have, the more effective you will be in carrying out this type of intervention. So I think there's a number of places to look. I mean, just starting with the tool itself, there are a number of online resources there that you can access. Again, tailored locally to each province and territory. It is worth spending some time just looking into those and exploring those. And those will guide you to some of the key income security benefit programs that are out there. They'll guide you to some of the key community resources that are out there. And will start to give you a sense of an understanding of the types of benefits that are available to your patients. We do run intensive workshops called Treating Poverty, so workshops that are focused on learning these types of interventions in detail. Right now we have a workshop that's accredited through the Ontario College and actually through the National College as well. It's a full 6-hour, highest level accredited workshop. It's actually wonderful. It goes through every type of poverty intervention, from individual interventions all the way up to higher level advocacy. And we've had really good reviews. I'll actually be running it at Family Medicine Forum this year. And it is available to groups that are interested in having us come out to do it. And we've done it across Ontario. We are willing to leave the province as well, or train people in other provinces to run it. The other part of the question was about higher level advocacy. I absolutely think that we can and should become involved in advocacy towards social policy change on issues around poverty and other social challenges to our patients' health. I think we're really well positioned to do this, actually, and I've been doing this for many years, and I can tell you there's a very particular voice that I have as a family physician in carrying out this type of advocacy. And it really goes back to those two motivators that I talked about at the beginning, right? So first of all, I'm able to bring forward real stories from the front line of care, which bring a real credibility and a power to my voice as an advocate. And second of all, I am an expert in bringing forward evidence, right? So policymakers really do listen when we bring forward policy commentary from an evidence-based perspective. Although I think if I was going to give one piece of advice to those of us trying to be advocates, I'd say speak from our hearts and speak from our positions as family physicians. Speak about what you see on the front lines, and that brings an incredible power and strength to our ability to advocate for change, social policy change in this area.
Thank you. We received a question about the workshop, actually. People wanted more details about the workshop when it was available. Someone mentioned that there was going to be one in Toronto on November 24th.
Yes. So the workshop again mostly runs in Ontario. It is coordinated through the Ontario College of Family Physicians. They actually list on their website the dates that they have organized to run it, but they also do take requests for the workshop. And we have a number of facilitators trained to run the workshop. And again, we are available to really run this across the province in many instances. And we can usually find a facilitator to go just about anywhere in the province. And again, we have done versions nationally as well. So those of you who are in other provinces, feel free to contact the Ontario College of Family Physicians, and we can have a discussion about how to provide the workshop in that setting.
Great. Thank you to Jen T for that question. We have another question from Lloyd Purdy, who asks, can you explain what a low-income patient can expect next after doing their tax return? Are the benefits you described received automatically? And what additional support or next steps are frequently required?
So it's a really good question. I mean, the tax return issue, the tax return piece is actually the easiest intervention that I think we can carry out. So for a low-income person with a very simple work situation, or if they're on social assistance, for instance, really does not have to put a lot of effort into filling out the tax return. It can often be done in half an hour or an hour, sometimes a bit longer if they haven't done it for a few years. And from there, it just goes to Canada Revenue Agency, and the benefits do come automatically. The benefits like the ones that I laid out for the case that I presented earlier. And for someone like that person that I talked about, so someone who gets child benefits, someone who gets seniors benefits, for instance, that's honestly where we find a lot of the most significant income benefits that are out there. There's, of course, a whole range of other benefits that people can access. And this is where I encourage you to start having conversations with your patients about their particular situation. So for instance, figuring out if they may qualify for disability benefits, right? And disability benefits vary by province. Some of them are nationally administered, some of them are provincially administered. but very, very important and highly effective support programs that are out there for people with disabilities. Finding out if your person is Indigenous, if they've been declared what's called a status Indian, for instance, may access a whole other range of benefits. If your patient is a senior, they're again, depending on their work history or how they've come into this, may be able to access a whole other range of benefits. So what I would say is that this really starts to become about your interest in developing your knowledge and skills in this area. Again, the interventions on the poverty tool are very high impact, but are just kind of a starting point, right? So if you want to start delving into understanding the rest of the system, I absolutely encourage you to do that. And again, that's what we do in our training sessions on this. But that's where you can kind of build this out. But if you want to stop with the tool by connecting with your patients through the questions there, you'll have done a huge amount for many of your low-income patients, and I think that's wonderful.
Thank you. Another question that was submitted in advance. If a patient does not outwardly show signs of poverty, how as a physician can I broach the subject in a respectful manner? It's a delicate topic, and I'm wondering from your perspective, what are some ways in which I can start this conversation?
So it's a really good question. It's a question I get asked often. It's actually a question that we spend a lot of time exploring when we're teaching around this. And I don't think there's one right way to ask your patients about their income. But I do think we need to have this conversation with everybody. And I really appreciate that you've framed this question around the fact that you just don't know which of your patients are living in poverty. So I think that one approach is the single question that's presented on the poverty tool, and I think that is a good approach. It's been shown to be easy to engage in and very effective in identifying people who live in poverty. I think there's also the approach that's a little slower and more narrative focused, right, where we get into more of a conversation about how our patients are living, right, what their housing situation is, what their employment situation is, what their social supports look like. And then through that, start into an understanding of really what the context of their lives is, and weave in perhaps more subtle or perhaps at some point even more direct questions around what their income is, right? And really how it is that they are surviving month to month on their earnings, right? And in some cases on their savings. So I got to say that my ideal in this area is the more narrative approach, but I think it takes more work and I think it takes more time. I think it is worth it. I think we can gather a very rich body of information about our patients that becomes useful in almost every aspect of the care we're trying to provide. But if nothing else, start with the simple screen. I also do want to mention that we have started to test, we and others actually, in other locations have started to test different ways of identifying patients who live in poverty. For instance, there's a group at North York General in Toronto that's run a study identifying patients by postal code, which is available through Statistics Canada, links postal codes with income level. We're also engaging in a study that looks at giving patients a survey on a tablet computer, which would then generate answers that will identify patients who live in poverty. People have done it through searches of electronic medical records, looking for clues in the record. You know, to me, nothing completely replaces a fulsome conversation with a patient, but in the interests of time and pressured practices, I think there are many ways that we can start to build this into what we do. And I think you'll start to see, as these research studies start being published, ideas of how to do this that may fit in your setting.
Great, thank you. We have a patient that asked a question. It's Judy Patterson, and she asks, my unique situation is the combination of poverty, isolation, she's in remote Northern Ontario, and the fact that most of the services and programs are solely for First Nations persons. Is there a way to reconcile services for those unable to travel due to remoteness combined with poverty? Is there a way to access services for these patients virtually?
It's a really good question, and thanks for asking it, Julie. I hope there are supports that you can draw on locally to help you with that. And the specific supports I would look to, first of all, are your family doctor, if you have one, if it's someone who is able to help you navigate this. And ideally, if that person's working in a team with a social worker or others who might be familiar with resources in your local area. There are excellent community resource lists available online, and actually the best portal that I recommend around that is 211 Ontario. And they have a website, 211ontario.ca, or you can literally just dial 211 into your phone in most parts of the province and speak to a highly trained person who can help you navigate the community resources that are available near you. On the internet, if you're interested in specific income benefits resources, the Government of Canada runs a website called Canada Benefits. It's canadabenefits.gc.ca. The website allows you to put in some of your demographic information, some information about yourself, and then generates a list of different programs that might be appropriate to you. And so they'll generate things like, northern travel grants or remote electricity supplements, these sorts of things, along with some of the more traditional income security, income benefit programs. So I'd encourage you to go online and start exploring some of those, along with accessing hopefully your primary care team and then the 211 system. And hopefully through that, you can start to build up a sense of what is actually available to you. But there's no question that this becomes much more difficult in rural and remote settings. And I think I certainly am very aware of the challenges that you face. And we are developing a version of the poverty tool for your setting as well, but it is not ready yet.
Thank you. We have one more question, and that is, are there success stories or models of care that have been implemented successfully and are able to share maybe an example of a success story?
Sure. So I think there are success stories on a number of levels. I think the one I'd like to talk about, because it's one that I'm really excited about, is the Income Security Health Promotion Program that I mentioned in our team at St. Mike's. So again, this is a program we now have 2 full-time income security health promoters. We applied for these positions through core family health team funding with Ontario's Ministry of Health. Right, and they granted us permanent funding for these positions. This wasn't through research funding or other special pots. This was just through us being creative with how we wanted to structure ourselves as a health team. The program's been in existence now for about 3 years. And I can tell you that our income security health promoters are busy. They are seeing over 400 unique patients per year through referrals, and those numbers are actually going up significantly. They're running workshops, which are available to patients in our family health team, as well as patients in the community around us, focusing on things like access to benefits for low-income patients or managing debt. They've done one specifically focused on seniors, so really trying to meet community needs. They're also engaged in training other health providers in our team, so improving our ability as frontline health providers to identify the specific social needs of our patients who live in poverty and carry out or better carry out some of our income interventions, like how to fill out disability application forms as one example. Over time, they are actually, and they've started into this, but they will start gathering some of their stories from the front lines to actually feed up into social policy advocacy as well. So they're really acting on just about every level that I think is important, from individual patients doing intensive assessments to community level in terms of the education, working with our health team, and then right up into social policy advocacy. So really exciting. And from the research side, we are actually just starting into a randomized controlled trial of this service. So in a couple of years, I hope to be able to come back here and talk about some of the results that we've had from really well done research on this type of intervention. I can tell you that this is unique globally in terms of this type of intervention woven into a team like ours.
Thank you very much. It's now 8:30. Thank you all very much for joining us. If you wanted to access the poverty tool, I've put a link in the comments. It's at www.cfpc.ca/poverty_tools. And thanks again for joining us and asking us your questions. And thank you very much to Dr. Block for joining us.
My pleasure. Thank you.
Great. Have a good night.
Thank you.